we are going to start our session. And just before beginning, can you please acknowledge whether everything is fine at your end? Audio video is fine at your end? If everything is fine, then we can begin our session. Is that all okay? If everything is fine, then we can. Yes, audio video is fine. All right. So, dear friends, I'll be giving certain questions with the timers on, and after that, I'll be giving certain questions without the time limit. Okay. So let us start with this particular question, and the timer has started. So let us now you start attempting this question and put your answer in the comment box. Okay. Let us start with the discussion now. Solve this question and put your answer in the comment box so that we can start the discussion now. Basically, here I'm going to teach you one concept. Okay. Yes, the timer is off now. What is your answer? What have you marked? Yes, dear students. What do you think will be the answer? The answer is C. C is the correct answer. Why? See, let me tell you, when we talk about the splanchnic nerves, splanchnic little meaning is like viscera. Okay. Those are the nerves which are going to supply the viscera. So by and large, when we talk about the splanchnic nerves, we know about the greater splanchnic nerve, lesser splanchnic nerve, least splanchnic nerve. So we can say all those splanchnic nerves which we know are nothing but the sympathetic nerves, okay? And those sympathetic nerves are going to supply the viscera, so they are also splanchnic. But then pelvic splanchnic are those nerves which are taking origin from S2, S3, and S4, not L2, L3, and L4. It will be S2, S3, and S4, and they are P for pelvic, P for parasympathetic. So they are P for pelvic, P for parasympathetic. Okay, if they are parasympathetic, they are nothing to do with the sympathetic. That's why only choice which fits in here is C. Then there's a term which is called as inferior hypogastric plexus. What is that? We will come back to this point in a while, but before that, let me give you one more question. Okay, so this time I'm going to remove my video out like input from here. So you focus on the screen and tell me what is your answer. After the timer is off, then I will give you the concept. Yes, beta. What is your answer now? So let me give you this concept. Before coming to this nerve part, particularly which the question is about, let me ask you. Yeah, good evening, beta. Sam, good evening. Hello, everyone. And let me ask you guys this particular question that which nerve is the one which is going to, you see, which is the one for, you can say, evacuation or secretion. In all the body systems, if you talk about the body system as a whole, the nerve for evacuation or the nerve for secretion is parasympathetic, except in the reproductive system. Only in the reproductive system, when we talk about ejaculation, which is the evacuation, is not done by the parasympathetic. If it is not done by parasympathetic, it will be done by sympathetic. Is that all okay? If the sympathetic is doing this particular role, then what's the role of parasympathetic in case of reproductive system? Yes, this is something very important for us to know, that parasympathetic will be doing the erection. So parasympathetic erection, sympathetic ejaculation. This we need to remember. Otherwise, in all other body systems, like you can say defecation, urination, okay, secretions of whatever, you will see the parasympathetics are involved there. Is that all okay? Now that was one part of the concept. The other concept over here is, if you look at the name of the nerve, nervi erigenitis, that means nerve for erection of genitals. If this is the nerve for the erection of the genitals, it should be sympathetic or it should be parasympathetic. What your common sense says. Obviously, it is parasympathetic. If it is parasympathetic, with that respect, we can say it is autonomic. Yes. Parasympathetic, yes. And just now we learned S2, S3, S4. It should be reaching over. It should be coming from this. What about choice D? That should be our answer. That should be our answer. It joins superior hypogastric plexus is false. Now, if it is false, what we should know about it? So please remember, we have two hypogastric plexus, superior hypogastric plexus and inferior hypogastric plexus. Truly speaking, if we speak like absolute anatomically, then superior hypogastric plexus as well as inferior hypogastric plexus, they both have both type of fiber, like sympathetic as well as parasympathetic. But so far as our exam is concerned, like NEET, INI, there we are talking about, you can see the most suitable answer. In that case, we can take this particular input, that S for superior is predominantly S for sympathetic, even though we know some parasympathetic will be there, but predominantly it is sympathetic. So please remember, S for superior, S for sympathetic. If the superior plexus is for sympathetic, inferior plexus will be for parasympathetic. Now, our nerve was parasympathetic. It must join with the inferior hypogastric plexus, not with the superior hypogastric plexus. Now, please tell me, dear friends, did you understand the concept? In the previous concept, in the previous question and this question, I have talked about autonomic nervous system in brief, particularly the sympathetic and parasympathetic, how they are reaching the viscera. But uh, as a whole, this concept is clear or not? Can you please confirm me that in the chat box? Have you understood this concept so that we can proceed further? I would like to show you something. So that I want to know whether this concept is clear to you, beta. Everyone, can you please write in the chat box whether did you understand this or not? So if I show you this question here, where like in the previous question, what you could see, that we have the pelvic splanchnic nerves and we are saying it is parasympathetic. If it is parasympathetic, with which plexus it should reach? It should reach the inferior hypogastric plexus, and this is what it was given in the choice. Now, the complete sentence makes sense. Yes or no? The preganglionic parasympathetic fibers to inferior hypogastric plexus. Very good, Dr. Apurva. Thanks for the confirmation. And your answers are also correct. Very good, beta. Now, let me tell you one thing about this. The next question. Okay. First, you observe this picture and try to think of this, like what is this given mark structure? And then I will be asking about I'll be asking a question about this structure. So first you identify this. Have you understood about this, the mark structure? Now let us take this question. All the following statements about the marked artery, this is a given hint, it was an artery, are true except that it. So what will be your answer? What was the marked structure and what will be your answer? Now, dear friends, what will be your answer in this question? What will be your answer? So, this question, let us first look at the structure over here. So, you can see this is the pancreas over here, right? This is the pancreas, right? And here you can see the liver is there, right? And this is the duodenum. This is the duodenum, okay? And what has been removed from here, if I add, okay, I can say that like what it should be here like this. The transverse colon will be in front, okay? The transverse colon will be in front, and from here the stomach part has been removed, okay? This is the cut part of the stomach, so we can directly see behind, and we can see one tortuous artery going above and reaching the spleen. It should be splenic artery. It should be splenic artery, okay? And here we can see this is the common hepatic artery, which is giving proper hepatic artery, and this one is the gastroduodenal artery. Gastroduodenal artery will give further two branches, but let us right now focus on this particular portion over here. Now the splenic artery, dear friends, if this is the splenic artery, okay, where will be the splenic vein? Splenic artery is above the pancreas, but splenic vein will be behind the pancreas. That is what something very important. That's why we count the splenic artery as a content of splenic bed, but we do not count splenic vein as a part of stomach bed, because the splenic vein will be further behind the pancreas. It does not come in relation with the stomach, so it does not become a part of stomach bed. Now, did you understand the structures right now, like how the duodenum and other structures which I have explained? Is it okay? Now, with respect to the splenic artery, it is having the tortuous course. Yes. It is branch of celiac trunk. Yes. It is having the branches that anastomose freely. No, because the branches are end arteries. The branches are end arteries. They will not anastomose freely. They supply the greater curvature. Yes. So which one is not true? C is not true. C is the correct answer over here. C is the correct answer. Did you understand, beta? Everyone, C is the correct answer. Very good, Hemangi. Now this question, let us look at this question. Read this clinical history of a patient, and then we will see what is the what is the explanation, what is the concept behind it. Mark your answer in the comment box. Okay. So let me repeat. Okay, let me repeat. I hope now it's okay. Can you hear everything? All right. So let me you see revise this part. So we have the aorta, which divides into two common iliac artery, right and left common iliac artery. Common iliac artery will be dividing into internal iliac artery and the external iliac artery. Particularly, internal iliac artery is going to enter into the pelvis and it is going to supply all the pelvic viscera. So it is the artery of the pelvic cavity, we can say. But what about the external iliac artery? It will give other branches also, but major continuation will be in the form of femoral artery, which will enter the lower limb. So you can say by and large, external iliac arteries are going to take care of the lower limbs, and internal iliac artery is going to take care of the pelvis. Is that all okay? I hope the concept is clear. Now, when look at this patient's presentation, the patient is having the pain in both the lower limbs, both the legs. So pain involving both the legs means involvement of both the arteries is there. And also he's having the erectile dysfunction means the pelvic involvement is also there. That means both external iliac and both internal iliac are gone. So involvement of four arteries at same time will be less likely. So what is most common, you can say explanation here that aorto-iliac junction where the aorta bifurcates into the iliac. That junction, if there is obstruction, okay, then it will be affecting all four vessels, both external iliac, both internal iliac will be affected. Yes. And this obstruction must have been gradual. Okay. So all these are like arteriography of the abdominal aorta shows the blockage in the region. That is clear. Yes, that should be there. And the gradual blockage was there. That is why there is slowly there is advanced arteriosclerosis. Yes. And insufficient amount of the blood was reaching both legs. That's why there is a claudication. That is also justified. But the choice B says only right common iliac artery. No. Only right common iliac artery cannot justify the pain on the left side. It also cannot justify the erection problem. Is it all okay? So B is not true. I hope that makes sense. Everyone, did you understand the concept? So right now, what we are looking at, we are going through these questions, but with the help of these questions, we are going in a retrograde manner and trying to understand the concepts, because majorly what is more important in anatomy is your visualization. If you can visualize the structures, if you can visualize the arteries, nerves, visceras, and the concepts, then it is going to stay for longer duration. If you try to mug up, like some seniors will guide you that anatomy is nothing but mugging up. That's not true, because those like the one who has taken the wrong path will always say the path was wrong. No, you have chosen that. Okay, there was another path also available, but it was, yes, on this path it will be a little bit of hard work. Okay, but if you can do a little bit of hard work, and after that yours, particularly your grip on the subject will be way better than those who are guiding you, those who are you see telling you that it is a subject where you have to mug up, right? Anyway, dear friends, I hope everything is fine up to this much part, and let us move on. Question number 5, what do you think will be the answer? Again, the timer is on. Check the given history. The patient coming with the chest pain. Okay, he has undergone the angiography and there is a serious stenosis of the right coronary artery, LAD and circumflex. That means triple vessel disease. All three major vessels are involved here. Because all three major vessels are involved and 54 years old, the age, the vessel involvement, as a whole, you make the decision that you will go for coronary artery bypass grafting, CABG. Now, during this procedure, a portion of the vein is removed. Now, normally, if you ask me whether the vein is the preferred, no. Nowadays, we don't prefer vein, we prefer artery. Okay, but the question is not talking about what is the preferred vessel. Okay, question is saying that for some reason or the other, the reason is not given. Somehow, one vein was removed and grafted. Question is which vein you will choose. Yes. Now, let me tell you. If you ask me that what is preferred, I'll say artery. But if by chance you are going for the vein, among the vein, it's not the first choice, but among the vein, great saphenous vein will be chosen. Okay. So where you will be harvesting the great saphenous vein, it can be harvested at other parts also, but usually it is taken at the point where it is about to drain into femoral vein. So that is the part you can say near to the femoral vein. There we are looking at infero lateral to the pubic tubercle. That will be the site. That is the particular site we are looking at great saphenous vein. We are going to harvest it from there. Next question, dear friends. So some structure is given, some coverings or some you can say markings are there. Which of the following is correct with respect to the layers of the abdomen making the coverings of the testis? Testis coverings will be made by which layer will be made by what particular portion? Yes, if you can tell. Yes, dear friends, what is your answer? So let me tell you, when the testis descends, it comes like it will be passing through the layers after layers, and those layers will be putting the coverings on it. Fascia transversalis, let us look at this part. Fascia transversalis will be giving the internal spermatic fascia. External oblique will be giving the external spermatic fascia, but the internal oblique muscle will be giving the cremasteric fascia. So answer was C over here. Because if there is also one thing that transverse abdominis will not make anything, any cover will not be given by the transverse abdominis. So it is number two. Here we had two, here we had two, here we had two. Only choice which did not have transverse abdominis was only C. So in your exam, you must be knowing the concept, and sometimes the tricks will also help you. Okay. Now let us move on, dear friends. Yes, directly ask question. Lymphatic drainage of the glans penis is by. So even though the timer is on, you can tell me the correct answer. Then we will proceed further. Yes, can you tell? Do you know the answer? Yes. Let me see who can answer this. Answer is deep inguinal lymph node. And let me explain the lymphatics of the lower limb part. Okay. So why we will discuss about the superficial. So if you look at the abdomen, right, we have the abdomen like we have the abdomen, we have the gluteal region, and we have the you see this is where we have the lower limb. And so far as superficial inguinal lymph nodes are concerned, they are arranged in three groups. We have one vertical group and two horizontal group, horizontal medial and horizontal lateral. And here we can consider we have the umbilicus. So from the lateral part of abdomen, from the gluteal region and upper lateral thigh, lateral part of abdomen, gluteal region, and upper lateral thigh. So if you look at in your own body, lateral, lateral, lateral in continuity, all these lateral areas are going to drain in the superficial inguinal group of this particular part, which is horizontal lateral group. Horizontal lateral, this one. Okay. This is the vertical group. You can say vertical group. And if I ask you that which vein comes here to drain, so you will say that great saphenous vein will come here to drain, correct? So whatever is the territory of the great saphenous vein, in all those territories, whatever is the lymph will follow the vein. And along with the vein, the lymph will also reach here. And then the vein will drain into the femoral vein, but the lymph will drain into the vertical group of lymph nodes. And if you apply the same concept, then short saphenous vein is reaching the popliteal fossa. It should drain the lymphatics along it should drain into popliteal lymph nodes. Yes, it is going to drain into the popliteal lymph nodes. Lastly, we can say we have anterior abdominal wall, which is going to drain into the horizontal medial group. And also we have the perineum, which is going to drain over here. Among the perineum, we have certain structures. That is a little bit of detail is there. What is the detail? We can say that in case of male and female both, there will be anal canal draining here. Anal canal, which part? Below pectinate line. below pectinate line. In case of male, it is going to drain. Complete penis will be draining over here except glans. That's something very important because penis will drain here into superficial group, particularly which group? Horizontal medial group. But the glans will drain into deep group. When we say deep group, it is specifically draining into lymph node of Cloquet. That belongs to deep group. In case of male, scrotum will also drain into this superficial group, but testis will not drain here. Rather, testis will drain into para-aortic group. Para-aortic group. In case of only female, what will be your answer in case of only female? Vulva, vagina. Which part of the vagina? Below hymen. And uterus. Along round ligament. I hope that makes sense. All right. So far, so good. Next question. Now look at this part. Try to make the diagnosis and tell me what is the correct answer. Yes. What have you marked? What is your diagnosis? Here, the diagnosis is not inguinal hernia. The diagnosis here is the femoral hernia. How? Look at where's the bulge. Bulge is below the inguinal ligament and lateral to pubic tubercle. That means inferolateral to pubic tubercle. That was the position of great saphenous vein, just next to femoral vein. That means we are talking about the we are talking about the femoral region. We are talking about the femoral triangle. There is a bulge because within the femoral canal, okay, there is a femoral hernia. You remember the femoral sheath? So answer here will be C. Why C? Let me show you this diagram. So here you can see that we have the femoral sheath. In the femoral sheath, we have this medial compartment, this middle compartment, and the lateral compartment. Middle compartment is having the vein, lateral compartment is having the artery, and then we have the nerve. From medial to lateral, we have vein, artery, and nerve. So vein is medial, artery is just lateral to it, and nerve is just further lateral to it. And look at the nerve. Nerve is outside the femoral sheath. But within the femoral sheath, we have medial most compartment, which is further medial to vein. And that compartment is empty, which is called as femoral canal. It's like almost empty because little bit content is there in the form of lymph node. So femoral hernia, if it occurs, who is just lateral to it, that will be femoral vein. Now let me show you the next question. Hanji, what's the answer? So basically, we are looking at the structure which is also passing through the inguinal canal along with the spermatic cord, along with the structure which is passing through the inguinal canal, the major content. So in major content, if I ask you, like what's the complete content in case of male? Spermatic. What's the content in case of female? It will be round ligament of uterus. But in case of both male and female, there's a nerve also passing through. And what's that nerve? Ilioinguinal nerve. This ilioinguinal nerve will also be get compressed by the herniating structure. That is why it will justify the pain. Next question. Now, patient is having severe backache, okay, and there's a diagnosis at CA of kidneys there on the left side, and that particular you can say growth is blocking the drainage of testicular vein, so testis cannot drain properly. And we know the right testis and the left testis, they have different venous drainage. Right one will drain into IVC and the left one will drain into the left renal vein. If by chance the kidney itself is having some problematic thing, so then the drainage will not be received properly. So what happens, there's a condition, the testicular vein will become engorged, congested. Those type of veins are, the diagnosis will be, what's the diagnosis? Varicocele. Very good, correct answer all of you, that is varicocele is the answer. And let me show you, this is the normal arrangement of the venules. This is what you can see in the varicocele. Do you appreciate this part? Because in the varicocele these venules, they become engorged, okay, they become congested, and when you feel them, when you examine them, right, they give the feeling of as if there's worms in the bag, so bag of worms like that, okay. Now you have this question and apply the common sense here. Along with the concept, common sense can be applied and you can reach the correct answer, and I hope all of you will give the correct answer only. Patient coming with fatigue, abdominal discomfort, and there's a mass in the descending colon. And as a surgeon, you are going to you see remove that particular mass. Which particular area? Descending colon. Now that's a big hint. What artery you will remove? Obviously, common sense says the one who is going to supply that particular region. So in the normal circumstances, descending colon is supplied by which artery? We know the descending colon belongs to the left side of the gut, or you can say hind gut region, where the normal supply is by inferior mesenteric artery. Superior mesenteric artery is the artery of midgut. This is the artery of hind gut. External iliac artery is the artery of lower limb majorly, and internal iliac artery is the artery of pelvis majorly. So answer will be D, because we are removing the mass in the descending colon belonging to hindgut. So we will consider inferior mesenteric artery. Making sense, beta? Very good. Sudhanshu, you have given the correct answer. Next question, the timer is on. The cystic artery arises from the right hepatic artery. We have already seen, you remember? Common hepatic artery. We have seen the splenic artery. This common hepatic was giving proper hepatic, and the proper hepatic will further divide right and left. The right hepatic artery will give cystic artery. The question is, the right hepatic artery will give cystic artery, which will be passing between an angle between two structures. One of them is common hepatic duct. What other structure makes the angle? Straightforward answer. It's very easy type of question, right? What will be your answer, beta? If you can tell, answer will be yes, quickly. A cystic duct. Why? Let me show you this diagram. So you can see the proper hepatic duct artery. You can see the right hepatic artery over here. You can see the left hepatic artery over here. And you can see this one is the cystic artery. And what you can see over here is the common hepatic, common bile duct. Like how to say common bile duct or simply bile duct? Because let's start from this. We have right, okay, hepatic duct. We have left hepatic duct. So what is this? Is the common hepatic duct. Common hepatic duct, and from the gallbladder, this is the gallbladder. From the gallbladder, this duct is the cystic duct coming. So cystic duct and common hepatic duct, when they join, they make common bile duct or simply bile duct. Now you can say cystic artery is between the angle in these two structure. What two structure? Common hepatic duct and cystic duct. Is it all clear, everyone? Clear now? Solve this question then. Now this is little bit related to the first concept. We were talking about sympathetic and parasympathetic. Now this will also give you one clear understanding of one major concept, and then those who can solve this question, good. Otherwise you will learn the concept, and after that there will be no problem. Okay, so let me give you the concept here. Let me tell you that when we say that we have certain nerves which are sensory, certain nerves which are motor, right? What about the our like spinal nerves? Spinal nerves are all mixed. Okay, spinal nerves are all mixed. They will be having the sensory fibers, they will be having the motor fiber also, and they will be reaching the different tissues. Like for example, we have the median nerve territory, we have the radial nerve territory. So all those nerves will be having the motor component, sensory component. Along with that, they also have one autonomic component. So sympathetics will be delivered via the nerves. So wherever suppose musculocutaneous nerve, for example, it becomes lateral cutaneous nerve of forearm. So lateral region of the forearm, it will be supplying the sensation also because it is cutaneous. Along with that, it will be also supplying the sympathetic fibers. So for the periphery, for the skin and otherwise, we can say sympathetic fibers will be reaching via the spinal nerves. You can say that. But what about the visceras? For the visceras, there will be no spinal nerves reaching. Yes. So visceras ke liye there will be another concept. First of all, they come from the thorax, they enter the abdomen. That's the first point. But once they enter the abdomen, they have to reach the viscera. Now let me tell you one thing with the concept, with the analogy. Suppose you move to one another city where you are new, but you have some product which can be sold. Okay, so you will go to a person who has got already very good distribution system within the city. So you will go and make a partnership that okay, you have got the distribution very good, and I have very good product. So let us become partner. I'll give the product, you distribute it, and you then we will share the profit. So same thing, sympathetics will reach over there and they observe that aorta is already sending the blood vessels to each and every tissue in the abdomen, correct? So what they do, they make plexus with the branches of the aorta. Okay, and when the branches will divide and reach the tissues, reach the visceras, the sympathetic will also divide and they will also reach the viscera. So wherever the arteries are going, sympathetics are also going. So in nutshell, in our periphery, the nerves will carry the sympathetics. For the visceras, the arteries will carry the sympathetic. Now, for example, if I say, now you have to tell me if you have understood the concept, beta. Can you please tell in the comments that you have understood this concept? For example, if I want to send the sympathetic fibers to liver, which plexus I will choose, celiac artery or superior mesenteric artery? So I will go in a systematic manner. We know the sympathetic will go with the artery. So indirectly, we should know which artery will reach the liver. We know the hepatic artery will reach the liver, but hepatic artery is a branch of what? It's a branch of celiac trunk. So if I put the sympathetic with the celiac trunk, it will divide and it will follow the hepatic artery. Via the hepatic artery, it will reach the liver. Do you understand this? Exactly in a similar manner, for the gallbladder, it is the cystic artery. Cystic artery comes from hepatic artery. Hepatic artery comes from celiac trunk. So which plexus should be there for the gallbladder? For the gallbladder, it should be celiac plexus and not the superior mesenteric plexus. Rest all the statements are correct, but because of this, answer is B. Because the fibers will go via celiac plexus. Please confirm everyone, did you understand this concept, beta? Is it all clear? And if it is clear, it was a little difficult concept. I tried to make it as simple as possible for you, but you being the brilliant student must have understood by now. Yes? Okay, tell me one thing that if I want to send some sympathetic fibers to hindgut, descending colon, with which artery I will put the sympathetics? Yes? Any idea? With which artery I will send the sympathetic? Okay, so let me explain this. Okay, no problem. Just a moment. Okay, so I'll say this way. Sympathetics for viscera. Sympathetic for viscera will be called as splanchnic. Okay, they will go to the branches of aorta and gets distributed. For example, foregut structure will be distributed with the help of celiac artery. Midgut structure will be by superior mesenteric artery, and hindgut region by inferior mesenteric artery. Are you understanding? For the hindgut, artery is inferior mesenteric, so it will go to inferior mesenteric for the hindgut. For all the foregut, foregut means what? We have the liver, pancreas, gallbladder. Also, they are getting supply from the celiac artery only. So that's why the sympathetic will also be following accordingly. Did you understand now? Is it all clear, everyone? Please give me quick feedback. Have you understood this now? Now solve this question. If you ligate the common hepatic artery, it will impair the blood supply in. Answer is straightforward here. Very good, beta. Sudhanshu, Apurva, Himangi, and all others. Right gastric and right gastroepiploic, because straightforward, this is the artery, right? If you're blocking over here, the right gastric artery will be also gone, hepatic artery will be also gone, so this whole area will be affected, no? So straightforward answer. Regarding inguinal canal, which is correct regarding the boundaries, okay? So check one. Which statement is okay here? Yes, Hanji. The timer is gone. Answer will be B. Why? Because transverse abdomen is not making interior wall. It's not there. Okay. Anteriorly it is not there because it ends in the lateral aspect. External oblique will not make posterior wall, it will make anterior wall. Fascia transversalis will not make floor, it will make posterior wall. Let me show you this particular picture. Over here you can see this is fascia transversalis. Along with this, that is conjoint tendon. Together, this plus this, they are going to make posterior wall. This is external oblique, which is making anterior wall. This particular and this particular, we have arched fibers of internal plus transverse abdominis, they make a roof, and we have inguinal ligament that makes floor. Okay, could you appreciate, beta? So please remember this. And what's the content over here is the spermatic cord. Now the timer is gone. Simply we can, this is like straightforward questions. What will be not present in the transpyloric plane? First thing, transpyloric plane will be present where? At the level of L1. Okay. Transtubercular will be present at the level of L5, and subcostal will be present at the level of L3. But anyway, regarding L1 level, first lumbar vertebra, fundus of the gallbladder, hilum of both kidneys will be present. Inferior mesenteric vein will not be present. Inferior mesenteric vessels will be lower down. That will not be present at the level of transpyloric plane. What other structures will be present? What other structures will be present? There will be neck of pancreas. And as the name says, transpyloric, that means it is passing through the pylorus of the stomach. Pylorus of the stomach. Okay. Superior mesenteric artery and spinal cord. Function of external oblique muscle. Now, if you look at the external oblique muscle, it is connecting the ribs, lower part of the ribs, okay, lower ribs, and then it comes downward. It is attaching to the iliac fossa, that means to the pelvic bone. Okay, so can it do the anterior flexion of the vertebral column? Yes. If both sided muscles will be working, they can do the flexion of the vertebral column also. Active expiration, yes, because if they compress, they increase the intra-abdominal pressure, they can do the active expiration, yes. Closure of inguinal ring, yes, that is also there because inguinal ring, the superficial inguinal ring itself is a defect within the external oblique aponeurosis. When the muscle will contract, both the crura will come close to each other. So it will lead to closure of superficial inguinal ring, and that's why all of the above should be correct answer D. Very good, beta. Answer is D only. Now, rectus sheath contains all of the following. As we understand, it contains pyramidalis muscle. Yes. It contains rectus abdominis muscle. That's why the name is rectus sheath. It contains what? Superior and inferior epigastric vessels also. They are present. Along with that, thoraco-abdominal nerves are also present. What are thoraco-abdominal nerves? Thoraco-abdominal nerves are nothing but T6 to T12. What about genitofemoral nerve? No, that is not present in the rectus sheath because it has got two components, genital branch and femoral branch. Femoral branch will be in the femoral triangle, and the genital branch of the genitofemoral nerve will be within the inguinal canal. Okay, particularly it will be a content of, you can say, spermatic Most important arterial supply to the stomach among all these is the left gastric artery, is a direct branch of the celiac trunk. Others are the branches of further branches, but here the lumen will be more, okay, and it's a direct branch, so that is the most important branch. False statement about portal vein. Yes. Can you tell? It is from the union of superior mesenteric vein and the splenic vein is a true statement. It passes behind the neck of pancreas and the superior part of duodenum is a true statement. Bile duct and hepatic artery, they lie anteriorly, that is also true statement. But is it dividing into hepatic veins? No. It divides into right and left branch of the portal vein only. And when you see this structure, right free margin of the lesser omentum, there we have portal triad. There we have portal triad, but how they are present? We have P4 posterior and P4 portal vein. So portal vein is the only structure which is posteriorly present in the lesser omentum right free margin. And then we have bile duct is there and hepatic artery is there, like that. Now this question, the patient coming to you and you have taken the patient for elective laparoscopic hernia repair. Now the word laparoscopy is important because you are looking these structures from inside only you can see. From outside you can't see. And the patient is a known case of inguinal hernia. So which landmark will be the best aid for the surgeon from direct indirect hernia? We have to differentiate. Answer will be A. Why? Inferior epigastric vessels, because if you see we have got you can say this is what you have from ASIS to pubic tubercle, you have got inguinal ligament Here you have the muscle, that is rectus abdominis muscle, and we have the ring, which is deep inguinal ring, and we have one artery, external iliac artery, which gives one branch over here, that is inferior epigastric artery. It becomes the triangle. This triangle is called as Hasselbeck's triangle. This triangle is called as Hasselbeck's triangle. Now, dear friends, look at this way. We have inferior epigastric artery and the ring is just outside, lateral to it. And if any hernia, it will be what? Indirect hernia. So indirect hernia will be lateral to the artery. Direct hernia will be medial to the artery. So artery is the landmark. I hope that makes sense. Which is not associated with the external oblique. Poppert ligament is the other name of inguinal ligament, and it is nothing but modification of modification of external oblique muscle only. Lacunar ligament, yes. Why? Because it is further extension of inguinal ligament. And superficial inguinal ring is a defect in the external oblique muscle only. But answer will be D. Why? Conjoint tendon we have seen, it is formed by internal oblique plus transversus abdominis. That's it. So far so good, everyone? Vein that does not cross the midline, straightforward answer is left gonadal vein. Why? Because it is going to drain into the left renal vein. We know that testis is a gonad. We discussed already that right gonad or right testis or right ovary, whatever you can say, is going to drain into the IVC, but the left side is going to drain into left renal vein. So the vein is on the left side. It will terminate on the left side only. So it does not have to cross the midline. That's why it never crosses the midline. Okay. So D will be the correct answer. Now check this part. Structure injured while resecting the free edge of lesser omentum will be all except. I have already given you the diagram. Okay, let me take you back over here. This was the diagram. What is this? This is the right free margin of lesser omentum. Right free margin of lesser omentum. It contains what? Portal triad. And within the portal triad, we have only one structure posteriorly present, P for posterior, P for portal vein. In among the portal triad, portal vein is posteriorly present. So who is anterior? Artery and duct is anterior. Artery will be anterior and on the left, and the duct will be anterior and on the right. I hope that makes sense, beta. Can you see that? So answer will be hepatic vein. Why? Because rest of the three structures are included in the portal triad. So those will be present. But the hepatic vein is not even considered in the this one triad, and it is not present there. If it is not present there, how it is going to be injured? Yes. Now, dear friends, I hope everything was fine, and the last question of today's session is this: downward enlargement of the spleen is prevented by. Yes, what is your answer? Downward enlargement of the spleen is prevented by what? What will be your answer? Straightforward answer is phrenicocholic ligament, which is also called as sustentaculum lineus. Sustentaculum means the support, linum means the spleen. So please remember, phrenicocholic ligament is the sustentaculum lineus. You can see this is the phrenic. Phrenic means the diaphragm. This is the colon. So this is the phrenicocholic ligament. Okay, this is the sustentaculum lineus. That means it is the support from below. So even if the spleen wants to enlarge, it cannot enlarge vertically downward because that is anyway blocked. So if at all it has to enlarge, it has got only one option, to enlarge in an oblique manner. So like for the clinical examination, whenever you examine a patient for splenomegaly, you will always proceed in an oblique manner. You must have learned in the clinics, right? So in the clinics, if you have not learned, you will be taught that you will go in an oblique manner in order to check for the splenomegaly. Okay, and even if the spleen is just palpable, because the normal circumstances it is not palpable. If at all it is palpable, that means at least it has become double in size. All right. So that was all, dear friends. Thank you so much, everyone. And you see, I'm just sharing with you guys my this detail. That is, this is my Instagram, Telegram, and that's my YouTube. And I will suggest you guys to please be connected with me on these platforms, so that whenever, like on the Telegram, I am giving some quizzes, on the Insta I'm putting some updates, and I'm planning for some live sessions also to discuss some small concepts. And the YouTube also we are going to utilize in exactly in a similar manner. So thank you so much, everyone. God bless you all. Take care.